Thank you all for coming. For those who don't know me, I'm Sam Gladstone. Ellen Kaufman asked me to introduce Jeff because she couldn't be here. I'm the ex-medical director of the PHO, although they haven't found someone else, so I'm going to keep doing it a half a day a week while I'm around. On Wednesday afternoon, so if you want to talk to me, I'm still going to be at the same number, 582-2225. I have been truly blessed to know Jeff since 1986. I came to the Valley in 85, he came in 86. It turns out that his wife and I are third cousins. And my uncle tried to get me to connect with, and Shelley's mother tried this connection, and it finally worked. And we met and have been close friends ever since.
And colleagues.
And colleagues. And I have to say, I was sort of blessed in my early post-residency life with a very dear friend in California who is a brilliant pediatrician who really taught me a tremendous amount about blessed with Jeff for all this time and how to think about goals. Just reading his consult letters was an education to me, and he was always open because I didn't always understand everything in the consult letters. So I would call him up and say, "What do you mean by this?" And he would patiently explain these things that were simple, secondary to him, which I didn't understand. So over these years, I think he's really helped me learn a tremendous amount. And lecture to base day, and when he told me about it and showed me, I said, "Oh, you got to give this here," because I myself struggle so much with trying to understand the issues having to do with statistics and what they mean versus the significance of them biologically, what they really mean. I remember, 20 years ago when Andy Larkin came and gave a talk here about Fate's theorem, which was part of this whole issue, which I remember was hard to understand, but got me thinking about, how I had been taught in medical school. So the only thing Jeff wanted me to say was that he has been an endocrinologist for 36 years. So I've said. So I don't want to take a lot of time. I want him to have the time. So he, of course, has no disclosures. That's part of what's so wonderful about him, because he speaks from really what he thinks is the truth. So we're going to do these true or false questions. So the first three principles of lipid drug management are to prescribe a statin. True? Please raise your hand. False. Okay. There is compelling outcome data that statins lower risk of atherosclerotic cardiovascular disease. True? 1.
2.
Thank you. Good. I'm assuming everybody else is false. A p-value equals...
Hold on a second. Wait a second.
False.
I'll go home now.
Okay, well, we got 2 true there. A p-value equals 0.06 in a drug interventional trial means that there is a 94% chance that the drug reduces events. True?
Great.
Okay. The benefit of statins for lowering risk of atherosclerotic cardiovascular disease far outweighs their risks. 1, 2, 3. True. That's not an answer. 4. True. Okay.
All right.
It's yours.
Thank you. Okay.
Oh, Guinness. Jeff has provided us all with Guinness. He's going to explain to us why. But there's a lot of Guinness there, so you gotta
drink that because I'm not a big beer drinker. And, I hear Guinness is a great beer.
I have to really explain the genesis for this talk, and why this is my first slide. Dr. Paul Thompson is a cardiologist, chief of cardiology at Hartford Hospital, and he is regionally recognized as an expert in lipidology, mainly I think because he has a apheresis unit. So they do LDL apheresis, and for people with genetic conditions of high triglyceride, they'll do plasmapheresis. So he's recognized as the go-to guy. So if, even in this hospital, if somebody needs apheresis for chylomicronemia or high triglycerides or even an LDL elevation because they have familial hypercholesterolemia and no other way to bring it down, he's the go-to guy. And so he came to Bay State in June, last June, and he gave this lecture, and I attended it, and it was going to be on treating severe hyperlipidemia or what to do when statins fail. But surprisingly, the first half of the lecture was really not on that topic. The first half of the lecture was really on the garden variety use of statins. And I had pretty much disagreed with pretty much everything he said in the first half of the lecture, and you can only interrupt the speaker so many times before he gets pretty annoyed, and he did get pretty annoyed, and he actually wouldn't take my questions at the end. So I asked the fellowship director, because there were fellows and trainees in the room, residents and medical students, and as well as the attendings that come to this conference weekly, I asked her, Mary Pat, to get the slides, and I would give the lecture, the first half of the lecture, again the next week, and explain my point of view. I gave the talk in September at Bay State, a brief version of this. So according to Dr. Thompson, there are 3 principles of managing lipids with medication. First principle is start a statin, because they knock the socks off the LDL. And this is something I don't argue with. This is true. These are the newer statins. He didn't include the first statin, lovastatin, but these newer statins, you can see 10 milligrams, almost a 50% lowering. Atorvastatin the same, simvastatin a little weaker, pravastatin. And the other thing about this slide is that when you double the dose, you don't get that much of a greater reduction in LDL cholesterol. So that leads him to tell us about the rule of 6%. So if every doubling of the dose reduces the LDL an additional 6% at baseline value. Now, he didn't really address why this is. Anybody know why this is? Why you double the dose and it only goes down a little bit more? Well, I'm not sure either. There's really not a lot of data. But the intracellular cholesterol metabolism is very tightly regulated. Cholesterol is toxic to the cell. So it's a very tightly regulated system. And it's regulated by these enzymatic conversions of acetyl-CoA down all the way down here to cholesterol through this more than 20 steps. And you get down to cholesterol. And when you block the production of cholesterol, you then upregulate the LDL receptors, and that leads to there was actually a debate at the beginning of this, back in the 80s, when these drugs were coming about. People thought, well, you lower the cholesterol, the serum cholesterol goes down because you're blocking cholesterol synthesis. Well, that's not actually how it works. How it works is you lower the intracellular cholesterol, and the cell senses that it needs cholesterol, so it upregulates the LDL receptors, but it also upregulates the enzymatic machinery to turn glucose into cholesterol. And so while you get a doubling or maybe a 1.8-fold increase in LDL receptor expression, this is human study. Somebody was doing a study. They were going to take gallbladders out, and they gave these men about 20 or 40 milligrams of pravastatin for 3 or 4 weeks before the surgery, and then they biopsied their liver, and they measured LDL receptor expression, which was increased almost 2-fold, and so inhibition of HMG-CoA reductase lowers LDL cholesterol in the serum because it upregulates the expression of LDL receptors. But at the same time, you see this tremendous increase in HMG-CoA reductase, 10 to 20-fold increase in the enzyme. So you're getting a upregulation of the enzymatic machinery to make cholesterol, and that's probably why you can't really lower the LDL beyond a certain level, which may be a good thing. Otherwise, you might kill the patient flat out. This was shown initially, the fact that these drugs knocked the socks off the LDL this was a dramatic publication and presentation on patients with familial hypercholesterolemia, where nothing worked this well, nothing worked nearly this well in patients who are missing half their LDL cholesterol receptors. These patients they're heterozygous for a defect in either the LDL cholesterol molecule, the apoprotein B, or in the receptor expression, and they only have half a complement. They generally run LDL cholesterol levels up in the 300 to 450 range, and really, before the 80s, nothing. Before this one study, this was so dramatic because you can only get these levels down 10, 15, 20% with diet and exercise and bile acid sequestrants, and so nothing really worked, and this was a pretty dramatic response that these investigators found to the first HMG-CoA reductase inhibitor that was used in humans, which is lovastatin, previously called mevinolin, right, or monocolin K. Monocolin K, that's the statin that's in red yeast rice, so it's lovastatin. It's basically the same exact molecule. They call it monocolin K. This was initially called mevinolin. Then they called it lovastatin. So this was presented in the early 80s, in 1983. This is a historian for the FDA who talks about how the cholesterol study published in 1984 really changes the thinking. So right after Illingsworth publishes his paper on statin therapy or lovastatin treatment, we get the results of the LRC trial on cholestyramine and diet, which actually showed, after an average of 7.4 years, an actual reduction in risk of endpoints, not just LDL cholesterol, not just the surrogate marker of risk, actual reduction in the endpoint, heart attack, death. And so synergistically, Brown and Goldstein figured out how it works. They just figured out the LDL cholesterol problem in patients with familial hypercholesterolemia, and they were about to win the Nobel Prize in 1985. And so all of these data together, Brown and Goldstein's work, the statin work, the LRC trial, it really spurred commercial interest in lipid-lowering drugs. And so Merck, who was working on lovastatin, submitted an IND in record time. And here's what's important. The decision by the Division of Metabolic and Endocrine Drug Products for the FDA approved these agents based on their surrogate lowering of the LDL cholesterol, just like he's saying, it knocks the socks off the LDL cholesterol. Okay, well, this issue has just come back again with the advent of another class of drugs that lowers the LDL cholesterol, these PCSK9 inhibitors. And these authors point out that while the FDA approval was based simply on the lowering the surrogate marker of risk, well, you know, that may not be such a smart thing to do because there are countervailing examples, niacin fibrates, in which lowering the LDL didn't improve CVD outcomes. In fact, they point to this study. This is a different class of drug that knocks the socks off the LDL. It even raises the HDL, which is high HDL is correlated with a decreased risk of atherosclerotic cardiovascular disease. Yet, despite the appropriate change or the desirable change in the surrogate marker of risk, the heart attack, the cardiovascular event risk and mortality goes up with that agent. So, what's going on? These authors call it the idolatry of the surrogate, and these aren't fringe players. You know, these are from well-established, institutions, the Mayo Clinic, Yale, University College of London, and they're pointing out that it's just easier to measure surrogate markers, and they're often used instead of really patient-important outcomes. These gentlemen are from the Healthy Skeptics Society, and they're pointing out that the short-term effects of treatment are visible. True outcomes may be years into the future, and that confuses the actual disease with the surrogate. And then you get this sense of uncritical acceptance of that evidence from clinical trials. It gives you this false sense of understanding and control, and that you have some mastery over the disease process. Take a look at this therapeutics letter from late 2014. This is a independent think tank funded by the government, part of the government of Canada. All these surrogate markers, are they really useful? And their conclusion is that relying on surrogate markers to assess effectiveness of drug therapy has not been proven to be useful, and you should avoid chasing surrogate markers of risk. They specifically point to the LDL cholesterol target. Second principle of lipid drug management is start a statin. Why? Look at the language. It cures almost every lipid problem that ails you. Okay? So it does the right thing to the LDL, it does the right thing to the triglyceride, it raises the HDL, it lowers CRP, it lowers the LDL small particles, which are really felt to be the most atherogenic LDL particles, and so more surrogate marker of risk evidence. Okay? That's the second principle of, that's why you should start a statin. Now, it really brings up the issue of how good are these surrogate markers, you know? How good is it? So if you had a perfect test, this is what it would look like, right? These are the normal people. These are the people at risk for in this situation, a heart attack. What does cholesterol look like? That's what cholesterol looks like. Okay, so this is from the Framingham study. This is total cholesterol. And there you see, you know, a couple of things about this graph. The mean for patients who are not destined to get coronary artery disease, right, is around 210. And the mean for patients who are going to get coronary artery disease is around 225. So that delta is only 15 mg%. Second thing is, look at this, 90%, it's a little deceptive, this slide, because it should go down to here. And so what does this mean? It means that people over 300, people with familial hypercholesterolemia, have only a 90% chance of getting atherosclerotic cardiovascular disease. 10% of them are never going to get it. So it's not sufficient, it turns out, just to have a high LDL, even if you have familial hypercholesterolemia, because 10% of these patients are protected. Now, the real point of this slide for Castelli, it's these people. So if you draw the line here, you're going to miss all these people. And that turns out to be 45% of the population, so that's a third of all patients with coronary artery disease. So if you draw the surrogate marker of risk there, you're going to get a lot of you're going to get a lot of false negatives. So another way to look at these data is this way. So this is a variable that changes, right? The LDL changes from 0 to whatever. And so you can, you know, sort of set it wherever, and you get, if you set it here, you won't get a lot of true positives. If you set it here, you know, you might get too many false positives. So another way to look at these data is to graph this out on what are called receiver operating characteristics curve, radio receiver, because this was initially started for radio men in World War II. And so this is how they figured out, are radio signals reality or are they false? And so they just basically graphed the false positive rate here versus the true positive rate here. If you graph it and it comes out with that line, that's worthless. That's the line of no discrimination. There are very few tests that look like this, which is perfect, right? And most tests look like this, somewhere between here and here, and this would be considered an excellent test, this would be considered a pretty good test, and this is obviously a worthless test because it's 50-50. This is like flipping a coin. Okay, so what does LDL cholesterol look like? So that's what LDL cholesterol looks like, and ApoB is the protein that's on, the single protein that's on the LDL cholesterol particle, so it's a surrogate marker for LDL cholesterol, basically. And so if you have very small, dense particles, your ApoB will be a little bit higher, you know, proportionally to the total LDL cholesterol. And if you take these graphs and you do what I did, which is kind of put it into this one, you can see that the LDL cholesterol measurement for, you know, it's not worthless, but it's not much better than worthless. It's, you know, it's sort of between worthless and good, okay? And so what about all these other surrogate markers? So we got ApoB, non-HDL, total cholesterol, calculated LDL cholesterol, triglycerides. They all have the same area under the receiver operating characteristic curve. So if you go back, obviously the area under this curve will be 0.5, and the area under this curve will be 1.0, and so these markers have about a 0.6. And that's true of LDL, ApoA1, HDL, HDL over total. The area under the curve is all around 0.6 to 0.7. Don't go running out, in my opinion, to measure C-reactive protein because it's really no better. Here's what the risk scores look like. Framingham risk score, UK-PDS risk score. The best test it looks like is the Atkinson score. You know what the Atkinson score is for coronary artery calcium scoring. So you put the patient in a CT scanner, and you can actually get a quantitative number estimate of how much calcium is in the patient's coronary arteries, and that's called the Atkinson score. And if you combine the Atkinson score, these are the most recent data, you combine the Atkinson score with a risk analysis, that seems to be the best, but it's still, you know, it's better than flipping a coin, but you know, it doesn't seem to be too terrific. And by the way, you don't want to follow the Atkinson score. If you put your patients on the drug, you don't want to be following coronary artery calcification scoring, because here's what happens. Progression of coronary, this is from the Heinz-Nixdorf recall study in Germany, where they took 4,800 people, And they did coronary artery calcification at baseline. They did it 2 years and 4 and 6 years in these 2 different studies. And look at this, age, blood pressure, lipid-lowering medication, diabetes, and smoking contributed to progression above the acceptance range in men. Now, this is not an error. This lipid-lowering medication increased the progression of coronary artery calcification. They then published these data on these are the lipid data that they published last year. After a short-term follow-up, atorvastatin really didn't do it unless you used 80 milligram, and then it did increase CAC. Long-term, low or high dose, it increased progression of CAC. Now that may not be bad, okay? That may not be bad, right? Cardiologist, right? Because it stabilizes the plaque, right? So this is their conclusion. Despite a greater CAC increase with high dose and long-term statin therapy, events did not occur more frequently in the statin-treated patients. So that suggests that the CAC growth represents plaque repair rather than continuing plaque expansion. But the problem with this is that, look at this, reference 4 was to this journal in 2005. They recruited patients from 2000 to 2003, so the follow-up is extremely short for that. And I'm not buying it, and neither are these editorialists from the American College of Cardiology. The never-ending story on coronary artery calcification, predictive, punitive, protective, multiple, this is the first observation, that statins are associated with an increased risk of calcium artery calcification. Multiple observations suggest that they seem to increase plaque density and CAC scores. And, is it good, is it bad? Whether it is noble to suffer CAC or to take arms against the sea of troubles still remains a crucial but as yet unanswered question. So on a little bit of a lowbrow note, kind of a art imitating life, I found this from 2002, before all the CAC data came out. Okay, all right, so the third principle, start a statin. Why? Okay, because they have incredible outcome data, okay? So here are the incredible outcome data. This is his slide on the incredible outcome data. Now, he didn't spend much time on this slide, but I'm about to spend quite a bit of time on these data because this is it, because if it lowers the surrogate marker risk, that may be good, that may not be good. What really counts is, does it lower the risk? So the first thing you do, the first thing I do when I look at a paper is, that's supposed to be lowering market risk, I look to see what kind of risk are they talking about, and you can see they're talking about relative risk. Okay, so they're not talking about absolute risk, relative risk. So, okay, so the best data here, 50%, relative risk reduction. Okay, so that could be 2 people in 1 person. That's a real 50% reduction. That could be 2 people in 100 to 1 people in 100. So that's the number needed to treat. If it's 2 to 1 is 2 to benefit 1 person. If it's 2 in 100 to 1 in 100, the number needed to treat is almost 100 to benefit 1 person. It could be 2 in 1,000 to 1 in 1,000. So you don't know anything from relative risk. You can't say anything. Second thing is you got to look at the x-axis. Well, we're not even talking patient-specific data now. We're talking about LDL cholesterol reduction. Okay, so they're taking the mean of the LDL cholesterol in one group, and they're looking at the mean in another group. So this is far removed from patient data, and it doesn't allow you to do what I just said, calculate a number of patients needed to treat. You can't do it if they present the data with LDL cholesterol reduction, because that's a mean, it's not fair to calculate NNTs from these kinds of data. This is a favorite way that the cholesterol treatment trialists who do a lot of meta-analyses on LDL cholesterol reduction and statin therapy present the data. And it comes from this, okay? So it comes from this kind of caveat or kind of rule of thumb that for every, based on, these clinical trials, for every 30 milligram percent reduction in LDL, the relative risk for CAD is changed by about 30%. Okay, now this is a log scale, so when you look at this study, here's that line on a linear scale. And it looks like she put all these studies, on this axis, and kind of plotted them out. And so these are the studies that she looked at. And oh, wait a second now. The 4S, that's the Scandinavian trial, so that's the first trial that showed, quote unquote, statistically significant reduction in risk. And then all of these trials came after it, and these are all statin trials. But the LRC trial, that's not a statin trial. That's a cholestyramine trial. The POSH trial, that's a surgery trial. So that really knocked the socks up the LDL, but that took intestinal bypass surgery. And Upjohn, that was a cholestyramine trial, NHLBI cholestyramine. These are dietary trials. So these aren't actually all statin trials. Hey, what's going on here? So to know what's going on, you got to look at the paper. So this is a paper by Robinson et al. From the Departments of Epidemiology and Biostatistics in Iowa, and they were looking at pleiotropic effects of statins benefit beyond cholesterol reduction. So they did a meta-regression analysis of all studies that looked at LDL lowering no matter how they lowered it, because their theory was that statins have other effects besides lowering LDL that's going to be good to lower your risk of atherosclerotic cardiovascular disease. And so it would be more than expected in the degree of LDL cholesterol lowering when you compared it to diet, POSH, surgery, cholestyramine, et cetera. And so that's really what this study is about. It's really not a purely statin study. And so she looked at the database, and she came up with 1,200 studies, and she boiled it down to 19. And then she plotted them along here. As she said, the crude risk estimates from the individual studies were replotted with their 95% confidence intervals. And then the dashed line is her line, okay? And is it close to this line? And it does seem pretty close to that line. Again, these are diet, these are the studies, these are the statin trials. And so their conclusion was the pleiotropic effects of statins do not seem to contribute to additional cardiovascular risk reduction beyond the benefit that you'd expect from just lowering the LDL. That's what that paper is all about. Now, this paper gets really interesting when you look at the statistical methods, which most people ignore, right? We all kind of just, we read the abstract, you might go to the tables and the graphs, and you kind of ignore the statistics. But that's the problem. You can't ignore the statistics. So it gets really interesting when you look at the statistical methods that she talks about. And so if you're willing to dive into these statistics with me, you might be, well informed, as Sam said, in terms of reading all of this literature. So, because, she is an epidemiologist and biostatistician, so she just can't eyeball this thing and say, hey, statins don't work any better, than anything else that lowers the LDL. She had to use statistics, and she used Bayesian methods, okay? Now, as Sam alluded to, about 20, 25 years ago, we had a lecture in this room on Bayes, and literally nobody could understand it except the lecturer. So I'm not going to make that mistake. But the great thing about Bayes, here's Bayes. He was a clergyman, and best known when he was alive for his theology. And he was apparently a brilliant mathematician, but he kind of kept it hidden. So he published this work anonymously, and then he chose to perish before he published this work, and which was published posthumously. And this is really what we're interested in, solving problem and the doctrine of chances, because this is all about chance, okay? It's all about probability. These days, you can actually see Bayes' theorem on, they're now published on, coffee mugs and T-shirts. Here's the theorem, it's the law. And the great thing about this is that it looks a little daunting, but it's actually translatable into English, okay? So I'm not going to pull an Andy Larkin. I'm going to actually tell you the English. Okay, so what it is the probability that the hypothesis is true, given the evidence, okay, equals the numerator, okay, the probability of the evidence occurring when the hypothesis is true times the probability of the hypothesis being true before you get the evidence, and then you divide it by the probability of the evidence under all circumstances, whether it's true or not true. So if this number is huge, this woman, this was a great way, look this up. This was about bomb threats, so it's so rare. So if this number is large, it doesn't really matter how big this number is. The probability is going to be really low. So you have to know this number, right? This number you can't know because that's what you're trying to figure out. Okay. So so you can, this has English meaning, it's easy to understand. I think it's understandable, right? Okay. So now she doesn't stop there. She says the Bayesian approach was chosen because it has natural clinical interpretations. Then she goes on and she disparages the frequentist approach as being not as informative as a Bayesian analysis. So what is she talking about, the frequentist approach? So frequentist statistics are like this. You measure stuff, and like you measure body weight, and it's going to come out. This comes out in a normal distribution, so-called Gaussian distribution, and you can make some kind of inferences from this that people are more likely to you're more likely to be in here than you're here and here, and that's, that's easy, right, to understand frequent inference.